Hello and welcome back to the best of the day from the great debates and updates in hematologic malignancies for 2015. The meeting has pretty much wrapped up for this year, and now we have an opportunity to sit down with the lymphoma chair for the meeting, Dr. John Leonard, who has been doing this with us now for a number of years.
Yes.
And John is a professor of medicine at Weill Cornell Medical Center and director of the lymphoma program, so someone very knowledgeable about all our topics for this afternoon. So John, welcome once again to Best of the Day.
Thanks. It's been a great meeting, and
Well,
it's nice
it
to have all
has.
these hot topics that we get in a short way.
It really is, and I think that the interesting thing about this meeting is it covers so many truly clinically relevant topics that come up in community practice on a very regular basis.
Right.
And I think one of the most common ones is that of follicular lymphoma. And we all have a pretty good idea of what to do with people who present with advanced disease, a lot of tumor. You know they're going to get R-CHOP to begin with. But the patients who present with advanced disease but aren't particularly symptomatic, have low volume disease, are not high FLIPI score, how aggressive should you be with them?
Right.
And that was the topic of one of the debates this afternoon, and Peter Martin from Cornell and Bruce Chesson from Georgetown talked about this. So kind of take us through that topic, what they had to say, and what you're doing in your center, and what you think people in the community should be thinking about and doing.
So we purposely, as you say, picked a case that would not only, we picked a younger patient because you're thinking not only short-term but long-term, and a patient that was just on the border of treatment, because I think, as you said, the person who's really sick, who has a bulky, transformed, or aggressive disease, I mean, that's easier to some degree. But that person who's just on the edge of needing treatment, they have so many different options. And the first, I tell patients, you have two questions. One is, do you have to do anything now or not? And once you're in the realm of, okay, it's time to do something, really the options are all over the place. And there's very little evidence that one choice versus another is better with respect to overall survival, which is obviously the gold standard endpoint that we're all looking for. So you really have a couple of different paradigms with these patients. And the first group, or the first, I guess, strategy is kind of the less is more strategy, from the standpoint of giving single agent rituximab, maybe just 4 doses, maybe with some maintenance, or perhaps combining a biologic therapy. And we talked a bit about lenalidomide, which has been studied both in combination with rituximab, both as upfront and in the relapse setting. So kind of the biologic or combination biologic approach, with the idea that kind of less is more. If you can control the disease, and if it's a person who doesn't have a lot of disease but needs treatment, if you can control the disease in an easy, relatively easy fashion, that would get some good mileage for the patient, and then you come in with chemotherapy at some point later, or frankly whatever we have in our armamentarium several years down the line. Versus the more traditional approach of saying, look, this is a patient who needs treatment. We might as well get him into a good remission, have a good CR, have a brief duration of therapy, 4 to 6 months or whatever it is of chemotherapy based on what you choose, whether it's R-CHOP or bendamustine. And then the idea that that's a relatively shorter duration of therapy, may be a bit more toxic, but may have a longer remission. And that's really the practical thing. And if there was an overall survival benefit, it would be easier. But with respect to quality of life, and we use PFS as our endpoint, but at the end of the day, that patient is there. They care about whether or not they progress, but really only if it affects their survival or if it affects how they feel. And so we really need to do a better job at measuring objectively quality of life, kind of area under the curve long term for these patients. But I think it's a challenge, and those are patients that I sit with, and I know people in the audience I'm sure sit with every day, and it's an hour-long discussion and about the pros and cons, and you could find yourself in one direction or another
I guess
very
the question
easily.
Sort of is a more aggressive approach to attempt to get a deeper response.
Right.
And since as you go along the line in multiple lines of therapy, the response durations tend to get shorter.
Right.
Should you do everything you can to make that first response
Right.
very long,
Right.
or should you just try to control the disease and preserve quality of life? And
Right.
it's a real question.
It is. And I think we're going to have some data on that with certainly lenalidomide rituximab versus chemo-rituximab. There's an ongoing study, the relevance study, which has completed accrual, and we'll see how that goes. I think it's going to be very interesting because obviously if one is clearly better, whether it's biologic approach or chemotherapy-based approach, that'll be easy. But if they're quite similar, we may not be any better off. And to some degree, I think the question of, well, okay, if something is more toxic, how much better does it have to be to justify the toxicity? And obviously, if it's survival, it's easier. But if it's quality of life, and again, the short-term quality of life of a brief duration of therapy that may be more intense, versus kind of the chronic nagging quality of life if you're on a therapy for months and months and months at a time, how we measure that and how that may pan out for an individual person, I think remains to be seen.
So I would assume with the relevance trial, we may get some response data fairly soon, but the progression-free survival is probably going to be a little bit delayed. Hopefully all those patients will have a fairly significant progression-free survival. So maybe a few years before we see.
I think that's the problem in follicular lymphoma is that you really want the long-term outcomes. And to some degree, it's almost like the story in Hodgkin's where shorter-term outcomes with radiation are better, longer-term outcomes with radiation may not be so better. And so, it may be similar here where you really have to wait a long time to see the full extent of one benefit or another with one regimen or another.
And there are so many new agents coming down the line that there's always a concern that by the time you actually get the full impact of the study and the final results, will it still be relevant?
Right.
Which is the name of the trial. So we'll just have to wait and see. But you, following that debate, you gave a very interesting discussion of some of these newer agents. I mean, we've heard data in CLL with the BCR signaling inhibitors, ibrutinib and idelalisib that are both available now.
Right.
But there are other BTK inhibitors and PI3 kinase inhibitors that are in clinical trials.
Right.
So tell us about some of these agents. I know we've already talked about some of the CD20 monoclonal antibodies and the antibody drug conjugates, so I don't know that we need to cover that again. But these small molecule inhibitors are really interesting.
Right. So briefly, because people have heard about the BTK, I think for lymphoma as opposed to CLL, for lymphoma the key take-home messages are that ibrutinib clearly is important in relapsed mantle cell lymphoma. The question of where it's going to be used, what it's going to be combined with remains to be seen in the future. In follicular lymphoma, ibrutinib, modest activity, again, probably in combinations. There's some ongoing studies. We'll see more there. When we talk about idelalisib, the PI3 kinase delta inhibitor, that drug is approved in recurrent follicular lymphoma, particularly refractory patients. So I think that's something that can be very useful, and I'm using it in my practice in that recurrent follicular lymphoma population in addition to CLL. Less helpful in mantle cell at this point, partly because of short durations. And then we have a couple of other PI3 kinase inhibitors in trials, some of which, and as I'm sure the audience knows, I mean, there are so many drugs targeting different isoforms of PI3 kinase. Many of them are being looked at in solid tumors. But we have copanlisib and we have duvelisib, again, with different isoform selectivity. I think that they all seem to have some activity in follicular lymphoma. Duvelisib seems to have a little more activity in T-cell lymphoma. But the real issue is going to be how do they differ from one another? How do they differ from other agents that are available for those patient populations? And ultimately, how do we combine them? What are the mechanisms of resistance? And the biology of these kinase inhibitors is such, as you know, that when you have a relatively precise target, although none of these are perfect, you can then start to look at, well, what happens in vitro what gets upregulated when you downregulate that, and therefore you can, I think, be more rational in how you develop these combinations with other targeted agents, perhaps more so than we are with chemotherapy.
A number of community docs that I've spoken to have been a little concerned about the black box warnings with idelalisib. And I know that this is an agent that you've used quite a bit in your practice. How big a concern is that? Is it just a matter of more careful monitoring of patients? Are some of these side effects, the colitis and the elevated liver function, these things that happen very quickly, or can they occur further down the line, or what has your experience been?
So the two issues that you refer to, the idea of having some GI toxicity, which is typically mild, typically some diarrhea, loose stools, but on occasion can be more serious, almost like a inflammatory colitis. And in that degree, you're really talking about somewhere in the range of 10% of patients at most. So the vast majority of people are not going to have that issue to a serious extent. And then the liver enzyme abnormalities that we see with idelalisib and some of the other PI3 kinase inhibitors. And that, again, typically it's a substantial fraction of patients, although roughly less than 50%. They're typically mild elevations. In roughly 20% of people, it's more significant, but in fact, those are really asymptomatic in the vast majority of cases. You monitor the patient, get the blood work, and stop the drug, pause the drug, and often can restart it at the same or a lower dose with really no problem. So
I think that's
for
a
most,
really important
it
point.
is important to keep in mind. So basically, when I start a patient on these drugs, at the beginning, I'll monitor them, check their liver enzymes, and see how they're doing. But for most people, it's really not an issue. The other important fact is that this can happen later. So it's not the sort of thing that you can say, oh, we're 2 months into it, 3 months into it, everything's great, forget about it, we'll see you later. These can happen a little bit later down the line sometimes as well.
Good. That's really important. Yeah. Let's move on and talk a little bit about mantle cell lymphoma. I know this has been an area of particular interest for you, and you have, over the years, sort of proposed being careful with mantle cell lymphomas, that not to jump in with your guns blazing, that some of these patients may actually have somewhat indolent disease, and so pick your patients and pick your treatments carefully. So we did have a debate. Koen van Biesen talked about the role of transplant, and then I guess you debated him as
kind of a variation of our day-to-day practice at Cornell.
But I know we all, in looking back on our years of practice, seeing some of the older patients with mantle cell who would get a nice response, but then relapse and not do well. And then we also remember the patients who presented very sick and got aggressive treatment and an auto transplant and have done great for 15 years. So how do you decide when you evaluate your patients, how do you decide which way to go?
Right. So I think one of the key messages that I think we covered in the debate was the fact that the FLIPI, which some of the elements of are similar to the IPI, particularly age, performance status, LDH, which people are used to checking in lymphoma, those are things that are really big determinants of outcome in mantle cell lymphoma, and those are very much skewed when you look at the literature. The more intensive regimens tend to be low-risk patients, again, because they're younger and fitter patients. And the less aggressive regimens tend to be more balanced based on, again, older patients and often less fit patients. So I think when you look at the literature in mantle cell, it's very much influenced by the patient population. So I agree with you. You have to look at the patient in front of you. You have to have a conversation with the patient. I think that clearly the value of aggressive treatment approaches is that the patient stays in remission longer. But the value with respect to overall survival is really less well established. The randomized data to look at that are very old, and relatively old at this point, but really I think influenced by a number of different factors. So that being said, I think that it is appropriate to, patients have lots of different options. I think that certainly transplanting patients in first remission is an appropriate thing to do, as well as perhaps less aggressive approaches, whether it's bendamustine, whether it's some of these novel drugs is incorporated. Now that we're starting to be able to give patients second, third line regimens that are effective, if they're not going the more aggressive route. Again, what we really need, as we alluded to before in the follicular discussion, is quality of life. Because, are you better off getting a more intensive approach and having a long remission, or are you better off getting a less aggressive approach, perhaps less acute toxicity, but perhaps a little bit more nagging chronic toxicity, either from ongoing or repeated treatments, or the disease itself and the stress of having it come back a little bit sooner. So I think there are lots of options, and we're really at a point where we could revisit randomized trials in this setting. But I think really the biases, and myself included, of physicians and patients are such that it's hard to randomize patients at this point, I think, to intensive or non-intensive. And what we really ought to be doing is focusing on making these approaches, all of them across the board, better, and figuring out how we use our novel agents most effectively.
So I know that one of the drugs available for relapse over the years has been bortezomib, and there have been trials trying to incorporate bortezomib up front along with CHOP, just switching out the vincristine and using bortezomib. What about ibrutinib? Ibrutinib is now available for relapse disease. Can you add ibrutinib into a cytotoxic chemotherapy regimen? Are they compatible? And is this being looked at as far as potential frontline therapy?
So there are data, certainly in large cell lymphoma, with R-CHOP and ibrutinib, and there are data with bendamustine, rituximab, and ibrutinib. And in fact, there are randomized trials looking at both of those agents in a number of different lymphoma settings. And so I think we will get some of those data. It's also worth noting that if you're more in favor of a more aggressive approach, the European Mantle Cell Network has a trial where they're basically taking patients and giving them either R-CHOP, DAP, which is their combination intensive approach followed by autotransplant, versus R-CHOP, DAP, autotransplant, and ibrutinib as part of that, versus R-CHOP, DAP, no autotransplant, and just ibrutinib. So that's for younger patients, and essentially asking the question, can you substitute ibrutinib for an autotransplant, or do you add it to an autotransplant, or does it not matter at all? So that's an interesting approach that is underway.
And how important is the role of high-dose Ara-C in the upfront management of mantle cell?
I think that the data that have come out of the European network really suggests that there are associations with outcome, and that I think most people have said, look, if you're using an aggressive approach, Ara-C is probably a good regimen, or a good component of that regimen. And if you're going to head in the transplant direction, you should do that. It's interesting now we're starting to see Ara-C containing regimens without transplant. BR Ara-C is an example of one. And I think, on the flip side, in the older patient population, the bendamustine rituximab-based approach is there and very commonly used. And in fact, our intergroup approach right now is a randomized 4-arm trial of bendamustine rituximab with or without bortezomib, and then there's a maintenance, which is either single agent rituximab or rituximab lenalidomide. So again, looking at those sorts of combinations of relatively novel agents in this setting.
Very good. Let's move on and talk about double hit lymphoma.
Yes.
This was something I had never heard of until several years ago when you and I were planning the agenda for this meeting, and you said, I think I'll talk about double hit lymphoma. And I said, go right ahead. I have no idea what it is. But so this has become a very important subset in diffuse large B-cell lymphoma. So explain a little bit about what is meant by double hit versus double protein, and how big a problem is this?
So double hit lymphoma refers primarily to patients that have BCL2 and MYC translocations, although in the literature there are some other translocations or recombinations that have been implicated, but predominantly that's what we're talking about. FISH positive, looking at MYC and looking at BCL2. Double protein is essentially the same, but not at the genetic level, at the protein level. And so double hit, FISH, genetic, double protein, obviously protein IHC, and there are some IHC or immunohistochemistry cutoffs to call positive in this setting. So when you look at large cell lymphoma, that those groups comprise a subset of large cell lymphoma, and depending on definitions, depending on things, it's somewhere in the range of 10 to 15% of large cell lymphomas either are double hit or double protein or both. Interestingly, the double hit by FISH tend to go with germinal center subtype, and the double protein expressing without the FISH tend to go with the non-germinal center subtype or ABC subtype. And so what that means is that this group incorporates a number of the patients in the umbrella of large cell lymphoma that have a less favorable prognosis, and they tend to go along with less favorable IPIs, tend to be older, advanced stage of disease, high LDH, et cetera, perhaps have a little more CNS involvement as well. So that group of patients, and identifying those group of patients that have a less favorable prognosis has two effects. Number one, if you rigorously look for those patients and pull them out as a separate category, the rest of large cell lymphoma probably is going to do better because you're pulling out a lot of the bad actors. And so that has huge implications for our clinical trials, and we talked a little bit about that in the session, particularly when you're trying to compare to historical data. When you pull out the bad guys, so to speak, the good guys do better, and where you go from there with the rest of large cell lymphoma is a challenge. Now, the double hit group, we have very little prospective data there. And there are some retrospective analyses and some prospective analyses, but not entirely specific to the double hit group, suggesting that our dose-adjusted R-EPOCH may be an appropriate or a better treatment for that. Now, I don't think that's definitively established, but I think that's as good of a standard as we have, at least at this point, and I think many people have looked at these mostly retrospective data to use that as their regimen of choice, and in fact, those data give us some baseline to then start to look at new drugs, perhaps in combination with that as a backbone to improve outcomes. So I think people should start to look for double hit and double protein expressors in that setting. Think about R-EPOCH in that group, and also think about clinical trials, because this group of patients really does have kind of a much more inferior outcome.
So what kind of a diagnostic algorithm can you recommend out in the community? I mean, start off with immunohistochemistry for MYC and BCL2, and then if those are positive, stop there. If they're positive, go on and request FISH.
So I would say that it's hit or miss. It depends a little bit on the pathologist and what they're automatically doing, and I think different centers have different standard approaches. One could argue that some people have argued every large cell lymphoma should get IHC for BCL2 and for MYC and should get a FISH analysis. I don't know that that's necessarily cost effective, but on the other hand, you'll probably miss some double hits if you don't routinely do that. Where you're going to see more double hits is, again, older patient, perhaps more high Ki-67 if your pathologists are checking that, more proliferative, high LDH advanced disease. That is the place where you're going to see more of that. Now, I can tell you, I recently saw a patient, I think it's very rare, but I saw a patient, stage 1 excised double hit lymphoma, young patient, kind of the opposite of the poster child. And we had a lot of discussion as to what to do with that. So if you only go by what I just said, you're occasionally going to miss some. So again, that would lead some to argue to pretty routinely checking it because it may change your management.
What is the potential for the BCL2 inhibitors like ABT 199 in double hit lymphoma?
Right. So I think that's a very exciting approach, ABT 199 or venetoclax being a BCL2 inhibitor. It has activity in just about every B-cell lymphoma, CLL, mantle cell, large cell lymphoma, and follicular lymphoma. Very interesting drug. Obviously, if BCL2 is important, a BCL2 inhibitor would seem to be useful in those double hit or double protein patients. There are a number of ongoing trials combining ABT 199 with BR, with R-CHOP, and we're actually very much in the U.S. intergroup working together to try to look at this in the double hit group specifically as well.
That sounds very exciting.
Yeah.
Very good. Well, John, thank you so much.
Thank you.
Guys planned a great meeting. It was really interesting. There was a lot of participation and great faculty. So we really appreciate that. And you're sitting down with me to talk about it.
Okay. Thank you very much.
Thank
Appreciate
you.
it.
Thanks to all of you for watching this final segment of Best of the Day from the 2015 Great Debates and Updates in Hematologic Malignancies. I hope that next spring you'll add this meeting to your schedule and come to New York and get together with us. I think you'll find it very interesting and very educational. Thanks again.